you the idea about screen visible?
Yes, sir.
Okay. So the calcium and the anaesthetist. So first of all, you must know the physiological actions of calcium. Calcium plays a very central role in large number of physiological actions that are essential for our life. So what are the physiological regulations they do? It is all marked in red. Regulation, clinical features, causes and treatment of alteration in circulating. This is about the physiology, how it does. But when it comes to the altered pathological, so it can be more of a pathophysiology rather than simple physiology and pathology. So it gets altered in acid-base status changes, massive blood transfusion, cardiopulmonary bypass, and the role of calcium in ischemic reperfusion injury, myocardial stunning are important to anesthetists. So the red things are mostly physiological and the blue things are mostly pathological. So of particular relevance anesthesia will be on the effects of calcium on myocardium, vascular smooth muscle, blood circulation, and to some extent on the neuromuscular junction also. So you can enumerate the functions of calcium in the body into these categories. Skeletal mineralization, that is a very important thing. For the bone to be strong, you require calcium. So the maintenance of skeletal mineralization or density of the bone is maintained by calcium. It also is important for blood coagulation. It is important for neural transmission. It also helps to some extent in plasma buffering capacity. It is very important for normal enzymatic activity and normal muscle tone and excitability of skeletal and cardiac muscle. All these things are done by calcium. And here you can see even during the development stage of the embryo, from egg activation to early embryonic events, right and left, everything has got some effect on by the calcium. At the same time, the normal bone formation, blood clotting, neural transmission and brain function, heart contraction, muscle contraction, all these things are done by calcium, or calcium plays an important role in these physiological activities. Now coming to the physiology, the action on myocardium and vascular smooth muscle is more important for us as anesthesiology because cardiac contraction and relaxation are primarily the result of repetitive phasic increase and decrease inside the calcium in the cytoplasm of the myocytes. So each repetitive increase of cytoplasmic calcium causes a binding to troponin C, which leads to interaction between actin myosin, and that is how the cardiac contraction takes place, which all of you know. And the relaxation occurs mainly when the calcium is removed by the ATPase pump and transported back into the sarcoplasmic reticulum or to the outside. Calcium is mainly an extracellular ion. It is not an intracellular ion. Inside the cytoplasmic concentration is 1,000 times less than what is found in the extracellular fluid. So these pumps and exchanges all normally try to push the calcium out because it is not an intracellular ion. So the reduction in cytoplasmic free calcium concentration reverses the calcium troponin C binding so that the calcium dissociates from troponin C. This releases the interaction between actin myosin and promotes cardiac relaxation. So this is how the normal physiological action of the calcium on the myocardial muscles. And there is a combination with the calmodulin regulated protein also, which activate protein kinase and phosphorylates myosin, with subsequent activation of smooth muscle in the vascular smooth muscle also. So apart from its action on the myocyte, it is very important for the action on the, even if you can't remember all these individual names, we can write about the overall action. This individual mechanism, how the myocardial contraction happens, You have to write in your answer because that is the basic physiology that they expect in your answer, and how it regulates the contraction and relaxation in the smooth muscle also you can add in your answer. The second thing is how the coagulation is helpful. The platelets, the cytoplasm of the platelets contain contractile filaments of actin and myosin that enable activated platelets to change their shape and degranulate, release their granules. So increased contraction of cytoplasmic calcium in the platelets occurs as a result of thromboxane A2 formation from activated platelets, which stimulate actin myosin complex in the platelet also, and though they start to derive the change in shape and causes the degranulation to release the granules. Now, coming to the blood coagulation, calcium is a negatively and calcium with a negatively charged phospholipid is essential for the final three steps of enzyme action. One is it acts on the factor 9 and factor 10, and also extrinsic pathway factor 7 and which acts on the factor 10. It's also stimulated by that, and factor 10 which acts on the factor 2 thrombin. All these steps are possible only because of the presence of ionized calcium in the blood. And control of calcium homeostasis, you must first mention how much of calcium is there in the body. For a 70 kg man has 1.2 kg of calcium, which is 99% located in the bone. And in the plasma, the normal calcium concentration is 2.2 to 2.55 millimoles, or 9 to roughly 10.5 milligram per deciliter. And 50% of this is free ionized calcium, which is only active functionally. And 10% is combined with various anions, including bicarbonate, citrate, phosphate, lactate, and sulfate. And 40% is bound to proteins, especially serum albumin. So the total 100% is divided like this: 50% is active ionized calcium, 40% is bound to proteins, and 10% is bound to the anions. So the ionized calcium concentration is at least 1,000 times lower than the extracellular fluid. So it is mainly an extracellular ion, and this level is maintained because the cell membrane permeability to calcium is low. So it is not very easily transportable across the cell membrane. So it requires powerful mechanisms like active pumping to push the calcium from the extracellular space into the cytoplasm. So the maintenance of plasma ionized calcium concentration is accomplished by three main calcitropic hormones. One is the parathyroid hormone, the second is the calcitriol vitamin D, third is the calcitonin. And this picture tells you how the homeostasis is maintained. Here the normal calcium level, roughly 10 milligram per deciliter is given. And once if the calcium level rising in the level in the blood, then what happens? The thyroid gland releases calcitonin, which is the anti-calcium, which makes it get reduced from the plasma. So it goes out to increase the stimulate the calcium deposition in the bone, and then blood calcium levels decline to set point. So if there is an increase in the plasma calcium level, calcitonin is the regulator. So that is done by reduced uptake of calcium from the kidney, as well as mainly deposition of calcium in the bone by the osteoclastic activity. But if the calcium level comes down, then what happens? Falling calcium blood level, then parathyroid hormone is released, and this parathyroid causes release of calcium from the deposition in the bone, and also stimulates uptake from the kidney, and both of them, and also vitamin D helps in the absorption of calcium, which all help in raising the calcium level. So hypercalcemia is controlled normally by calcitonin. Hypocalcemia is corrected automatically by parathyroid and vitamin D. So this is a simple way of remembering how these uh, calcium levels are maintained or the homeostasis is maintained. Now the clinical scenarios of altered calcium hypercalcemia happens when the influx of calcium, which is how it is happening. And what are all the clinical features? GI tract, you may have nausea, vomiting, anorexia, constipation. And neurological, you have lethargy, fatigue, headache, muscle weakness, confusion, and coma. And renal, you have polyuria, polydipsia, renal blood flow decrease, decreased GFR, interstitial nephritis, nephrocalcinosis, hypercalciuria, and stone formation, urolithiasis. Blood, you may get a thrombotic events. And psychologically, patient may have anxiety, dementia, depression, instability, and psychosis. So the causes of hypercalcemia are primary hyperparathyroidism, which is the commonest cause of hypercalcemia. Malignancy is the second commonest cause of hypercalcemia and may be related to direct bone destruction or secondary calcium factors by malignant cells. Now, these are the causes of hypercalcemia at various levels, the mechanism. So, increased bone calcium reabsorption, one. Second is hypercalcemia due to decreased urinary calcium excretion. It is more reabsorption of calcium from the kidney. Hypercalcemia due to increased GI absorption. So, three levels are the main reasons for the increase in the calcium level. And how they are caused with the mechanism, increase in parathermone, and here for the mutation of calcium receptors, and here about the more absorption due to the activity of vitamin D. So these are all the picture to show what are all the various systemic effects, bones, stones, abdominal groans, and cyclic bones is the mnemonic to remember the hypercalcemia. And how do you manage hypercalcemia? Sometimes this may be a challenge to you. These patients may come to you with for some incidental surgery. The patients who have hypercalcemia, we have to manage them. For mild hypercalcemia, where a calcium level is between 10 to 12 milligrams per 100 deciliter, they are usually asymptomatic. So no active medical management is needed, but avoid these drugs in them. Thiazides, lithium, high calcium diet. They should not be volume depleted, and prolonged inactivity should be avoided. And for moderate hypercalcemia, where the calcium level is between 12 to 14 milligram, if they are asymptomatic, just watch them, observe them, and you can take them up for surgery. But if they are symptomatic, you have to give intravenous normal saline, 300 cc per hour. That will reduce the serum calcium level. And if it is another method of treatment is using bisphosphonates, which will help to make the calcium go into the bone, get reabsorbed into the bone. So this is the second management. So dilution with normal saline or usage of bisphosphonate. For severe hypercalcemia, which is 14 milligram per deciliter, more than, then you can use all these treatment where you can use normal saline, you can use calcitonin, which is available as a nasal spray, and you can use Sensipar, furosemide, bisphosphonates, and recurrent hypercalcemia, very severe hypercalcemia, you can do parathyroidectomy, you can have antibodies injection, and lastly hemodialysis. So these are all the management that sometimes you may get a case of parathyroidectomy for hypercalcemia, which is not amenable to medical management. So you have to know this particular condition. The opposite of hypercalcemia is hypocalcemia, where the net effect is because of overexcretion as well as reduced reabsorption or the release from the bone. So, and also after thyroid surgeries, where accidentally the parathyroid glands also have been removed, you come across hypocalcemia in the post-operative phase after 24 hours of surgery, where you get hypocalcemic muscle twitching and cramps and the respiratory depression, distress, all these things happen. All of you know about that. So if the value goes to less than 2 milligram, it will be life-threatening. So yes, up to some extent, it will be normal. So it is always imperative that you should measure the minus calcium level before thyroid surgery, which is a common question asked in the examination also. The features of hypercalcemia, again, they affect the same systems. Paresthesia can elicit choke shock or Prof sign, muscle cramps, tetany, muscle weakness, hyperactive reflexes, and convulsions. And the respiratory system, laryngeal spasm and bronchospasm. Cardiovascular, you may have hypotension, impaired contractility, bradycardia, arrhythmias, and sometimes cardiac arrest, ECG changes, PTSD prolongation, and PVA inversion. And psychiatric, anxiety, dementia, depression, irritability, almost something similar to what you get in hypercalcemia also. Now the causes are, medical causes are chronic and acute renal failure, vitamin D deficiency, magnesium deficiency, acute pancreatitis, or hypoparathyroidism, and sepsis. Now, surgical causes are post-parathyroidectomy, post-thyroidectomy, and post-cardiopulmonary bypass. And iatrogenic massive blood transfusion, phosphate and citrate or calcium infusion, radiographic contrast high, they also can result in hypocalcemia. Now, how do you treat hypocalcemia? Again, this is the way. Symptomatic hypocalcemia occurs when calcium is less than 1.9 millimole. For control, within minutes to hours, you have to give IV calcium gluconate, which is very urgent. For asymptomatic or mildly symptomatic patients, where you can take your time, where the treatment can last for days to weeks, you first give vitamin D treatment. If the patient has parathormone deficiency, you have to give vitamin D analog calcitrol or alpha calcidol. Starting dose 0.5 to 1 microgram per day and increase every 4 days. If the parathormone levels are normal, can give polycalciferol or indocalciferol, typically 50,000. Nowadays, we all know that many patients are vitamin D activated vitamin D3 deficient, and they are all given vitamin D supplementation, either weekly dose of 60,000 units or daily dose of 2,000 units. That's the way vitamin D supplementation is done in a slow fashion. But if it is urgent, imminent conditions with severe choke strain and muscle cramps, then you have to give calcium gluconate 10 ml, 10% over 10 minutes. If persistent, then recurrent infusion can be given at that rate for every 4 hours. Another point is, what are the available preparations? This is a viva question they may ask you. You have a calcium gluconate, which is 10%, which has got 9.3 milligrams of elemental calcium. The other preparation is calcium chloride 10%, again 10 ml ampules, but the calcium available is almost 3 times more, 27.2 milligram of elemental calcium. So once the ionized calcium concentration is stable, calcium may be administered by enteral route. So after correcting the hypocalcemia by parenteral administration, you have to, especially if you find that patients have lost their parathyroid also during thyroid surgery, especially total thyroidectomy, you have to continue oral supplementation of calcium lifelong further. There is no way you can stop that. So calcium can be given by enteral route with a dose of 1 to 4 grams of elemental calcium per day. When calcium alone is not sufficient, then you have to add vitamin D metabolites also. However, definitive treatment is recognizing the condition and then correcting the disorder. Now coming to anesthesia, during anesthesia, several factors alter the serum ionized calcium level. So what are all the conditions that may lead to alteration is presence of malnutrition or low albumin. As you know that 40% is bound to albumin. So if the patient has with liver disease has a low albumin, the free ionized calcium concentration will go up. Similarly, abnormal acid status and electrolytes during the will also alter, and transfusion of large volumes of saturated blood and the use of cardiac perfusion solutions. All these things are the causes for altering the calcium level. And many actions of drugs during is due to indirectly due to the calcium action. For example, the hemodynamic alterations induced by benzodiazepines are mediated in part by the inhibitory effects on the sympathetic nervous system via inhibition of voltage-dependent calcium channel or calcium currents, preventing calcium entry into the vascular smooth muscle. The midazolam directly relaxes airway smooth muscle again by decreasing cytosolic calcium. So the calcium which enters the cytoplasm of any smooth muscle cell stimulates the production of cyclic AMP, which is the main cause for the contractility of any muscle or any cardiac muscle or the smooth muscle. So the oxybarbiturates exert their vasodilatory effects by reduction in the intracellular calcium. And myocardial depression and vascular dilatation caused by varying extent by all volatile anesthetic agents. They also alter the calcium influx. And calcium channel blocking drugs exaggerate the effects of volatile anesthetic agents on myocardium and vasculature. And non-depolarizing muscle relaxants seem to be potentiated by both hypo and hypercalcemia that are more obvious in presence of muscle weakness and atrophy. Acidemia will also decrease protein binding with subsequent increase in ionized calcium. And cardiotoxicity of bupivacaine may be increased in the presence of hypocalcemia. So if the person who has suffered from bupivacaine toxicity, if the cardiac contractions are not returning despite your intralipid, check the calcium and correct the calcium, then it may revive the heart. Alkalosis increases the binding and reduces the level of ionized calcium, and clearance of citrate from blood will be decreased during hypothermia if liver function is impaired, and therefore rapid transfusion of small volumes of citrate containing will also cause a serious reduction in serum calcium level. So this has to be taken note in liver transplantations where large volume of blood sometimes may be required. And the levels of ionized calcium should be monitored and corrected during cardiopulmonary bypass also. And hypocalcemia present as lymphospasm, especially immediately after thyroid surgery. Calcium was found to reduce inotropic action of epinephrine in humans. And coming to this particular special situation, calcium and ischemic injury, increase in cytosolic calcium may be detrimental cell by activating calcium-dependent phospholipase, results in breakdown of cell membrane and producing free radicals. This is how the ischemic peripersistent injury generally happens. And calcium also activate destructive proteases and nucleases and disrupt adenyl cyclase, sodium potassium ATPase activity, and other important calcium regulated cellular enzymes. And agents that decrease calcium influx may ameliorate ischemic injury. So if you are able to prevent the entry of calcium into the cytoplasm, that may mitigate the severity of ischemic injury. Then in myocardial stenosis, contractile dysfunction that occurs following a period of ischemia that is not associated with necrosis is known as myocardial stenosis. So the myocardium is not contracting properly, but it is at the same time has not become totally necrotic because of lack of blood supply. So calcium influx during reperfusion may be the cause for stenosis. So duration of non-depolarizing relaxants is likely to prolong if the patient has hypercalcemia. And patients with hypercalcemia may benefit from hyperventilation and respiratory alkalosis. And greater myocardial depression and hypertension may occur with anesthetic agents in hypocalcemia. The action of muscle relaxants may be prolonged and smaller doses may be required. So hypo and hypocalcemia both will affect the action of muscle relaxants. So these are all the importance of calcium to anesthetist. So you can classify them into the physiological aspects, then the situations of hypercalcemia, hypocalcemia, their importance to anesthesia, and lastly the various individual anesthetic drugs and calcium, and the special situations of calcium ischemic injury and myocardial stomach. Okay? So this is how can I think classify the answers and try to present the